cannot tell you how honored I am to introduce today's presenter. Today's speaker is more than just one of the best surgeons in the world. He's a leader and an educator in his specialty, but most importantly to me, he is my hero. Hero is a word that may bring one to envision either superhero capes or superpowers or x-ray vision or even tights. Though I can't quite imagine Tom Sonnanstine in a cape or tights, I have been a direct recipient of his superpowers. So I never really struggled with weight or even really was a big guy until a few years after college. But then life happens and kids happened, work happened, and pretty soon I found myself with less time for healthy meals or being as active as I should. It's not an excuse, but it's my truth. My entire life suddenly somehow became centered around food. Celebrations, funerals, business meetings, date nights, friendly get-togethers were usually accompanied with a pretty heavy meal and some drinks. So I started to gain weight. I then found myself on that newest fad diet and the next popular idea to lose weight. From Atkins to weight loss pills to ultra-low-calorie diets, I began to yo-yo. So I'd lose 20, gain 30, lose 30, gain 50, and wham, I was pretty overweight. I kept telling myself I'd just go back to Atkins or stop eating anything with sugar or flour or go on that new fad diet to get back to my studly college self. That didn't happen. After I was diagnosed with diabetes, knee problems, 2-foot surgeries, and high blood pressure, I was pretty much hell on wheels in the express lane for an early funeral. Worried about flying because I needed a belt extender, worried if the plastic chairs, lawn chairs would hold me, worried if I'd see my daughter walk down the aisle, worried if I'd see my son play his next hockey game, or worried if I'd ever be able to retire on the beach with my pretty awesome wife. So I did what most men and women find pretty hard to do sometimes. I had a pretty frank conversation with my family doctor and was referred to Dr. Tom Sonnanstine. So 3 years ago, pretty much this week, I entered the program with Dr. Sonnanstine. I weighed 451 pounds. I was a size 54, 56 waist. He and his amazing team of dietitians, psychologists, nurses really, truly helped transform my life. Bad habits were out the window. I was checked over head to toe and inside and out, and I was ready for surgery. One word of advice, my daughter sent me a link of the YouTube video of the surgery. Don't ever YouTube or Google anything that you're about ready to go have done. So thanks, Mackenzie. But this man, he's my hero. But he's who you're here to listen to today. So I'll conclude with this. I was scared. It's a scary thing. And he calmed me. I was dying, truly, and he saved me. I was diabetic. He cured me. I was heavy. But he taught me the way to a healthy life. You know, the old adage, teach a man to fish. Surgery was a tool to get me close, but he truly empowered me to get me to my goal weight on my own. So 2 years ago this week, I had my surgery. As of this morning, I weighed in at 251 pounds, so a little bit down from 451 pounds. Still a little heavy according to those charts that say I should look like Fabio, but, you know, for the most part, I'm pretty healthy. So 200 pounds lost, and I'm living proof that the magic that this man does in the medical weight loss profession truly does work. So I'm happy to share my story. I embrace it. I tell everyone I can that will listen to me about its benefits, but I'm truly honored and thankful to be able to be here today, 200 pounds less, to introduce my hero, my surgeon, and someone that I consider my friend, Dr. Tom Sonnanstine.
Thank you, Matt, and thank you, Rotary, for having me here today. It's definitely a privilege to be invited here today. I was having lunch with my mom and dad yesterday, and my mom reminded me that I was a Rotary Scholarship recipient 29 years ago. So it's thanks for having me today. It's I think the biggest challenge of today in my talk is going to be keeping this short. You know, this is something obviously I've got a lot of passion for, and I could probably stand up here for the next week telling you the ins and outs of bariatric surgery and what we do, how we do it, why we do it. But I think it's pretty cool that Matt was so willing to tell his story and is really proud of the work that he put into this, because I think above anything, the hardest part about what I do to help patients who are suffering from obesity and metabolic disease is the fact that there has to be a recognition that there's a problem, and then there has to be a recognition that it's going to take a lot of hard work to get a good result and to get the tool that is bariatric surgery. To say that this is the easy way out, I think Matt could attest to it, and hopefully everyone would quickly realize that the easy way out isn't getting surgery. It's hard. It's hard to accept that you have a problem. It's even harder than implementing the things that you need to do to change your life. And that means sacrifice, that means hard work, that means undergoing something very, very risky. That who wants to undergo surgery? So with that said, we'll go ahead and get started here. This is just kind of an update in bariatric surgery, a little bit about my background. I'm born and raised in Marion. Did my undergraduate work in Case Western Reserve in Cleveland, my medical school work in Akron, did my general surgery residency at Riverside. Came back and I took over the bariatric surgery program at Riverside just a little over 7 years ago. Very proud to be back here. This is home for me. It's where I trained, and I'm really proud of what we've built here. And just as a little aside, Callaway's son, Callaway, is actually my newest partner in my practice, and we're very happy to have him back for the past couple of months and look forward to the next 30 plus years of having a nice collaborative relationship in practice. This is just a kind of a busy chart, but it tells about the problem that we have not only here in the United States, but throughout the world. Every single every single country on the face of the planet has an obesity problem. I've operated in 8 different countries, some of the richest countries in the world and some of the poorest countries in the world. Countries in which just 30 years ago there was starvation happening. China and in India are the 2 highest or fastest growing rates of obesity in the world. This is a Western diet, this is increased wealth, it's a sedentary lifestyle, and it's the genetics that none of us can escape. So we've got some tools, and those tools are variable. Of course, dieting and exercise is a big deal. Fortunately, we're getting some slow but sure breakthroughs in pharmaceuticals. And then there's the big gun being bariatric surgery. There's over 200,000 bariatric operations performed in the United States every year, close to 1 million worldwide. And you hear me use the term bariatric surgery a lot. We no longer use the term obesity surgery. Bariatric surgery is actually metabolic surgery. Our primary goal when we're doing surgery on people who suffer from obesity and their diseases is to change the metabolism, change that genetic predisposition that patients have to being obese, and then of course the medical problems related therein. So what kind of options do we have today? Just a few. How many of them perfect? None. There is no perfect surgery out there, just as there's no perfect car or computer or cell phone or medication. We've got to try to tailor our options to our patients. Try to prepare the patients, educate them on the changes that are necessary along with surgery in order to be successful. You'll find that we really focus today, our gold standard operations are the gastric bypass, also known as the Roux-en-Y, as well as the sleeve gastrectomy. But I could probably list another 15 things besides this that are tried or experimented with and are dabbled with by surgeons both here in the United States as well as around the world. So gastric bypass, this is kind of my bread and butter operation. I do about 200 of these a year, more than any other surgeon in the state of Ohio. It's the operation that's been around the longest. It's the operation that has the best proven track record and the most efficacy of anything that we do. And without showing you a kind of here's your normal stomach and small intestine, this is what we do with surgery. It's a big operation. I did one this morning, took a little over an hour, and we do a dramatic rearrangement of the body's anatomy, specifically the stomach and the small intestine. And without getting into the nuts and bolts of it, our objective is really fourfold, and that's to decrease the amount of food a patient can eat. The new stomach that we make is about the size of your thumb, a small egg, size of a shot glass. It'll hold a little bit less than 1 ounce of food or fluid at a time. So it forces the patients to be really conscientious on how much food they can eat at once. Another neat thing about surgery is appetite, hunger, cravings are diminished dramatically. If you talk to a patient, we can ask Matt today, what's your appetite like? Many times, particularly that first 6 months or so after surgery, patients will literally forget to eat. and that's for a number of different reasons. Changes in hormone levels in the body, actual nerves that communicate between the brain and the stomach are altered. And then probably the most important thing about gastric bypass, and the operation that I feel is the best operation that we have, is its huge impact on diabetes. Diabetes is one of those few medical conditions that truly affects every single organ in our body. Literally from the top of a patient's head to the bottom of their feet, every organ in between is affected. Of course, it's related to weight. Not completely, but it usually is. And this is specifically type 2 diabetes that I'm referring to. But the biggest impact above and beyond weight loss that we see when patients have bariatric surgery, and specifically gastric bypass, is the huge impact on diabetes. Oftentimes patient I did surgery on today, a diabetic, when she leaves the hospital on Wednesday or Thursday, I can promise you the number of medications she's taking for her diabetes will probably be cut in half. Hopefully, literally within weeks, if not sooner, she could potentially be cured of her diabetes, just as Matt was. And for a patient who suffers diabetes and all these medical problems, it's really that impact above and beyond the weight loss that is their biggest motivator for surgery. And then number 4 is something called dumping syndrome. And without getting into the ins and outs of dumping syndrome, this is an adverse reaction that the new anatomy that we construct at the time of surgery will cause a patient to have side effects if they eat sugary foods, fatty foods, fried foods. And then you add all of these things together on top of the education, the support that we give patients. That's why we see such a profound impact on their weight and their health. This is 30 to 40% of the operations done nationwide. It's about 60% of the operations that I do. It's a very challenging, technically challenging operation, very long learning curve, lots of training, long-term follow-up. The idea of getting surgery and then just kind of getting on your way and not following up with your surgeon or program, that's something that we really discourage. We want patients to have long-term follow-up. Vitamin deficiencies can be an issue. We really stress our patients to take their vitamins. It's a risky operation. Nobody electively wants to undergo a major operation, so we have to weigh the risks and the benefits of each. Of course, the efficacy. How good does this operation, how good does it work? What kind of impact does it make on a patient's health, not just their weight? And then the impact on diabetes. What's our success rate? Well, everybody wants to know about weight loss. I can show you tons and tons of charts and studies that show improvement in medical problems, but weight loss is something that we tangibly see. Patients will lose, on average, 50 to 100% of their excess weight. That is weight above and beyond that ideal body weight that we all see and talk about. Matt's probably around 85%, so it's pretty impressive. I'm not going to go through this slide a lot. This is more of the conversation that we have with our patients and fellow professionals in the field, just really outlining the benefits of surgery, weighing those with the risks of surgery. It's very important that we do these operations at full-fledged hospitals. Riverside, I think by most measures, is one of the leading hospitals in the state. I've got all the resources that I could potentially want to help me help our patients, both before surgery, at the time of surgery, and there and after, to help decrease the risk of complications. Now let's talk about the gastric sleeve, or the sleeve gastrectomy. This is an operation that's quite a bit different than the gastric bypass. It tends to be a little less scary for patients, and it's actually the operation that's the most common weight loss surgery, bariatric surgery, both in the United States as well as worldwide. And with this operation, as you can see from the illustration, we take our stomach, which I like to call a big bucket that'll hold about 1.5 liters to 2 liters of food or fluid at once, and we remove about 85 to 90% of it. Cut it, staple it, divide it, remove it completely from the abdominal cavity. Now turning the stomach, no longer a big tube, or no longer a big bucket, but now a long, narrow tube. No rearrangement of the intestine, less risky, less demanding on the surgeon, less demanding on the patient, but still can be a good operation. Decreases the amount of food a patient can eat, changes their appetite, hunger, and cravings, again through those hormone changes and nerve changes, and can also give them dumping syndrome if they make poor food choices. So what are the advantages? Well, some of the advantages are it's less scary than gastric bypass. It's less of a dramatic operation to the anatomy. It means it has fewer long-term risks. What are some disadvantages? Still a great big surgery. We don't take this lightly. This is still a lot more than somebody going in and getting their wisdom teeth pulled or their gallbladder removed. It's still a forever operation, as we like to tell our patients. But probably not quite as good as far as weight loss goes. Probably not quite as good as far as improvements of medical problems, again, specifically speaking towards diabetes. And the weight loss success. On the low end, not quite as good. On the upper end, every bit as good for patients who are hardworking, motivated, and disciplined. Now, what about the lap band? Everybody knows about or has heard about the lap band. This is an operation that 10 years ago, if I was giving this talk to Rotary, this is what I'd be saying is the most common operation both in the United States as well as the world. Now, it's a dying operation. 10 years ago, probably 100,000+ of these done every year in the United States. This year, probably less than 2,000. It's an operation that, while it's much less invasive, much less risky to the life of the patient, it has a lot lower efficacy rate and actually the highest long-term complication rate of any operation that is available to us. So when you weigh those things, we've just decided collectively, most of us, busy bariatric surgeons, have decided that the risk-benefit ratio with the lap band just isn't where our other options are. Operation we'll just talk about briefly. The Bilio pancreatic diversion, duodenal switch. This is what I consider more of a fringe operation. Of all of the bariatric surgeries done in the United States, less than 5% are of this type. While it will give you better weight loss, it will give you better improvement of weight loss issues, it also can lead to some pretty significant lifestyle changes, increase in frequencies of bowel movement, a much higher need for patients to be absolutely diligent in taking sometimes expensive vitamins and supplements. So it's an operation that we in our program have chosen not to offer to our patients. And then revisional surgery. Well, now if you start doing the math and you figure out that 200,000+ patients a year here in the United States are getting bariatric surgery, not all of which are going to be successful. About 1 in 6 patients don't lose a significant amount of weight or lose their weight but subsequently regain. This leaves us with a number of patients out there who have either had complications or recalcitrance from their operation, requiring us to do revisional surgery. And this is something that we also kind of specialize in at Riverside here at Ohio Health. And that's the number of revisional operations that we get. And with the surgery, we see patients from surrounding states, the entire region that we live in here, coming back with either a complication or weight regain, that we've got to be really creative sometimes in the things that we can do, whether it's removing a band, whether it's converting a band to a sleeve or a gastric bypass, converting a sleeve to a gastric bypass. Of the 5 operations that I did last Friday, 3 of them were revisional surgery. Much more challenging, more risky. This is an operation that you might hear some buzz out there about. It's an operation that's kind of sexy, I guess, because it doesn't require making incisions on somebody's abdomen. It's not considered surgery per se, but it's work that can be done through the mouth. I mention this only because, again, there is buzz out there about it. It is something that we do not offer because there's not really any proven efficacy with it. And insurance companies, ever the arbiter here in the United States as far as who gets care and oftentimes what kind of care they get, particularly when you speak about the world of surgery, insurance does not pay for this sort of thing. So it's, again, something we do not offer. Just a variation herein are other things that we can do orally. We've got lots of fancy tools and equipment. We can put stitches in places, we can put clips and staple guns, we can change the anatomy of the stomach and small intestine, but there's nothing like tried and true surgery, where we have to take the scalpel out and we do surgery. Now, I didn't mention, I should have, I failed to, we do 99.9% of the bariatric operations that my group and I do are done laparoscopically. And that's specifically surgery through the small incisions. It's, knock on wood, been about 15 years almost since I've had to do an open gastric bypass, and I've never had to do a sleeve gastrectomy. So really all comers, patients upward of 600 pounds, were able to do these operations laparoscopically. It's good for us, but it's really good for the patient. Decreases their risk of complications, infection, pneumonia, all of those things. Shorter hospital stay, which ultimately can lead to improved expense and cost, quicker time back to life, to work, and more productivity. The gastric balloon. This is probably the newest thing that's out there. And here in town and surrounding communities, you'll maybe see even some advertisements on television. This is kind of where history repeats itself. About 25 years ago, surgeons were putting in balloons, literally balloons, into people's stomachs. That would then be a space about the size of your fist when that balloon is inflated, and it would give a patient the sensation that they were full. When they ate, take up room in the stomach, not allow them to eat very much. So about 5 or 6 years ago, the FDA approved a couple different variations of this, and it's back on the market. That's what it looks like, that big bowling ball or billiard cue ball that you see. Looks like an 8-ball, I guess, down in the left corner there. This is what a lot of surgeons out there are doing. It's, again, an operation that we do not offer in our practice. It's something that we've collectively determined the risk-benefit ratio just isn't there. And to ask a patient to pay cash for this, upwards of $4,000, $5,000, $6,000, and hope for 30 or 40 pounds of weight loss, and then have to turn around and remove this thing a few months later, is something that we haven't found is an ethical thing to do, or something that really fits in our practice at this time. About the endoluminal sleeve, this is probably above and beyond what we're here to talk about, but this is something that back when I was in fellowship in Boston back in 2003, we were working on and developing, and it's still in development. Kind of a novel idea, but changes the body's metabolism, really reinforces that our main operations, specifically the gastric bypass and the sleeve gastrectomy, are here to stay. About robotics. I think everybody's probably heard about the big impact that robotic surgery is having in the world of surgery, whether it's prostate surgery or gynecological surgery or general surgery. Robotics is huge in the world of bariatric surgery. It's a surgeon who is using a robot to assist him or her to do a laparoscopic operation. This is something we've talked about involving in our practice. I'm hopeful that Callaway will make a bit of an endeavor in this and determine whether he sees that this is something useful in his kind of armamentarium, so to speak, of tools and instruments that we have. But this can be beneficial for a patient, maybe. It could add costs. But it's certainly a kind of an exciting thing that is becoming more and more mainstream each and every year as more surgeons adopt this. What about complications? This is big time surgery. This is just a short list. I could talk about this all day as well. Complications in surgery. I'm sure everybody's got a horror story of somebody they know who knows somebody who had bariatric surgery and didn't have a good outcome. This is major surgery in patients who are high risk. So we worry about a lot of things. We like to tee the patient up, so to speak, that by the time, the day that we walk into surgery, they're as healthy as could be. Of course, that's oftentimes relatively speaking. While Matt was traveling the country and working full-time at a job, at 450 pounds with diabetes and sleep apnea and high blood pressure, he was far from healthy. Physiologically, we speak about patients who might be 20, 30, or 40 years that we're operating on, but physiologically, their body is 60, 70, 80 years plus because of the wear and tear, the risk of complications, and really almost more importantly, their ability to withstand or survive a complication should it occur. And that's another reason why doing bariatric surgery is such a big deal. It's something that is carved out as a very select specialty in the world of general surgery. And something, again, that we really are fond about practicing at a place like Riverside, where we've got all the incredible resources around to help us help our patients, because complications to some degree are inevitable. The body fails, it's less than perfect, and our tools, our instruments, our solutions are less than perfect. But the bottom line is, and what we weigh, is the risk of surgery higher than the benefits. And I can tell you, I've sat and I've had conversations with patients who are really, really sick. And I've told them there's a 1 in 20 chance that if we do this surgery, you're not going to either walk out of the hospital or perhaps you're going to die within the first 30 days if you develop a complication. In those cases, we've got to make sure that the benefits are higher than those risks. And most of the time, they are. Now, generally speaking, the risk of death is about 1 in 1,000 after bariatric surgery. Rewind 15 years ago, we were quoting 1 in 100. So we've made lots of ground, lots of headway over the years. Resolution of problems. This is the fun slide that I get to show patients. This is the preview to what their life is like afterwards. All the medical problems that you can imagine, the dramatic improvements that you will see. But really the most rewarding part about my job is seeing how a patient's quality of life changes. In the world of surgery, we don't often get to do that. You know, we're cutting out bad gallbladders or appendix that have ruptured or cutting cancers out of people. In this world, we're operating on patients who, of course, they want to get off of medications, but they want to get on the floor and they want to play with their children, their grandchildren, their nieces, their nephews. They want to go with their children to the amusement park or to the fair. They want to do those things to live. Wednesdays and Thursdays are my typical clinic days, very, very busy. And I can tell you, I talk about very little medicine or surgery those days. We spend most of our time talking about, well, what was your motivation to get surgery and how have you been rewarded with your surgery and with the hard work that you've put into it? And that, without a doubt, is really the most inspirational thing that I think you can have in the world of surgery, in the world of general surgery. And it's, I guess, why I'm a bariatric surgeon. What's recovery like? We keep patients in the hospital 2 or 3 nights. Patients typically miss 2 to 4 weeks of work. We advance their diet slowly. It's about a month until they're trying regular food. And it's about 6 months until they're really kind of feeling good about themselves on what they're eating, what they're tolerating. But they're giving up foods for the rest of their life. They are making sacrifice. We live in a world where our genetics, if they predispose us to obesity and metabolic problems, no longer can our patients, if they want to change the path that they're on, no longer can they indulge or even dabble in some of those foods and drinks that they spent a life doing. So, our program, by most measures, is the 2nd or 3rd busiest bariatric program in the state of Ohio. We're what is called an American College of Surgeons Center of Excellence. That means that we've been reviewed and vetted out by the American College of Surgeons based in Chicago as being a leader in the world of bariatric surgery. We're specially trained staff, facilities to take care of our patients. Tertiary care program in which we see patients from other programs, not only here in town, but throughout the state, throughout the region. We're multidisciplinary, and this is something I think we'd be remiss if I didn't mention, but this is a team. It's a team of our 3 surgeons, but also 30 people just in our building that we work in, with our dietitians, our psychologists, the nurses, the support staff that we have to help us get patients ready and then to be there for them long term. This is so much more than just doing surgery on our patients. And with that said, that's my portion of the talk. I want to thank you again for having me here today. And I'd love to give you an opportunity to ask any questions that you may have of either myself or Matt. Yes?
What might be a typical diet that one might be placed on after they have this?
For the first 2 weeks after surgery, it's a full liquid diet. And then it's a week of pureed foods and then a week of soft foods. But starting at a month, we start them on regular foods. We really stress for those first couple of months, stay away from the bread, the rice, the pastas, those carbohydrates. Focus on the proteins. We recommend that all of our patients do a protein supplement, a protein drink. We're really fortunate these days. We weren't 15 years ago when I started doing this, but we're fortunate now that there's so many supplements catered towards people who want to lose weight, watch their weight, and or have had bariatric surgery that you can get at supermarkets, on the internet. So a patient who's had bariatric surgery, as you've seen today, can eat at a buffet like this. But what they're going to do is their portions are going to be much smaller. let's say 5 to 6 ounces in a setting, it's going to take them 30 to 45 minutes to eat it. They may eat more frequently during the course of the day and less of those bigger meals that we all eat. And of course, they've got to be a little bit more selective and usually avoidant of desserts, the bread, the pasta, those sorts of things. They're eating normal, though, effectively. Yes?
I saw in one of your earlier slides, sorry, that you said pharmacological solutions. Is that something your department sees, and what is out there?
Yeah, so our program is nice. We have a surgical side and we have a medical side. So on that medical side, we do have some pharmacological options. Trade names such as Meridia, Xenical, Contrave. There are a few medications out there. Of course, pharmaceuticals have kind of gotten a bad name over the years with the fen-phen scare and a number of the things that were effectively amphetamines that have certainly an addictive component to it, side effects such as high blood pressure, things like that. We're limited. We're very limited, and the bar has been very high for the FDA to approve anything, just because so many of these medications work in the brain as well as the heart and vascular system, so our hands are kind of tied. But I think in those situations, still getting those patients involved in the mental health evaluation, the nutritional evaluation, all of those things. I can tell you, how much time we spent in 4 years of medical school learning nutrition? Maybe a half hour. So you can just imagine our kids these days aren't learning about nutrition and how we need to eat. Labels, reading labels is very misleading, very challenging. Yes?
How does insurance handle this?
So it's hit or miss. Most insurance policies will have coverage for bariatric surgery, of course, meeting certain criteria, but in government payers do. We're fortunate here in Ohio, as well as 32 other states in the country, that the state payers pay for it. Medicare, a federal payer, does pay for it. And then as far as commercial insurance goes, it really depends on the specific policy. Yes?
What do you guys use to go into considering what people's ideal weight should be?
Yeah, a good question. I'm not a big ideal weight person because I'm 40 pounds over my ideal body weight, and I don't think ideal body weight applies to a lot of us. More of what qualifies somebody for surgery is based on BMI or body mass index, and that's a ratio of height and weight. That number has to be 40 or higher without medical problems, or 35 or higher in the presence of diabetes, heart disease, sleep apnea.
When you're considering how close they've gotten to their goal, like what are you guys, obviously?
Yeah, I admittedly kind of do the eyeball test. I want to see a person's build. I want to see what weight they were when they started. I want to see their age. I want to see where they have their weight distributed. So I can't tell you I ever tell a patient that you need to get what the 1954 Metropolitan Life Insurance chart says that you need to be. I mean, that's just not a motivator for me, nor do I think it should necessarily be for our patients.
I'm going to have to take the 2 more questions, and I've seen Don's up for a long time. So, Don?
What do you tell them in regard to alcohol?
Good question. Alcohol. It's got to be in moderation. We like them to be abstinent before surgery for a couple of months and 6 months after surgery. It can affect them differently, but my biggest concern with alcohol is twofold. One, it's empty calories. And number 2 is there's something called replacement addiction. So now you have had surgery and you're replacing your addiction, your go-to that was food or snacking or chocolate, and now you have the potential of alcohol or even other ills in society. So I'm one that I feel if you say you absolutely can't do this, then you're probably going to have a patient who does it. But we educate and we warn them about the risks and pitfalls.
I saw some other hands up, and if you've made your contribution to the annual service campaign, keep them up. Okay, we have 2. Flip a coin, heads or tails. What'd you call, Steve? Heads. You lost. Dave Osbaugh, you get the last question.
As a follow-up or a follow-on on the psychology of it, with many addictions, people with food use it as a release or as a happy place to go or a stress reliever. With alcohol, tobacco, or opiates, you eliminate that. With food, that's impossible. How do you deal with that aspect?
Education, preparation, first and foremost. I think if I were to tell you what I think is the biggest downside to our healthcare system in the United States, it's our lack of mental health services. So we're already behind the 8 ball. You know, upwards of 15% of our patients have some sort of abuse, physical, emotional, sexual abuse during their life, and now they're seeing us. So we not only have to deal with the issues that they're going to deal with after surgery, but all of the issues they're dealing with on a day-to-day basis that may have led to poor choices, everything. So it's preparation, it's education, it's getting them plugged into the system as much as we can. And it's another thing I'm very proud about our program is our mental health component of our bariatric program. We use providers that work with our program on a day in and day out basis. They've actually come to the operating room with us. They follow up the patients, not only preoperatively, but postoperatively as well. And if I've got a crisis, so to speak, in the office, I get a quick telephone call, and within minutes, I've got one of our mental health providers down in the office, working with the patient, getting them extra support that they hopefully can get out in the community.
Thank you so much.
Thank you. Thank you.
Tom, thank you so much for not just being a guest speaker with your time, talents, but also being an inspiration. And Matt Allen is retiring. Thank you for being an inspiration. For those of you who'd like to watch this again, it's on our link on our columbusrotary.org website. You can also share that with someone else who might learn something about bariatrics. I didn't know the term a few years ago till my son and I were walking the golf course, and all the various surgeons were recruiting him. He said, "What do you want to be?" I said, "Bariatric." I said, "I don't even know what that is." So he basically said, "I want to change the trajectory of one's life." In terms of a happy buck, I'm awfully glad to have Matt Allen give that speech today. I'd also like to say I'm thankful for my granddaughter bringing our son's family back to Columbus a few months ago. To Dr. Sonnanstine for being his teacher, mentor, and friend, and now colleague and partner. Appreciate that. Thank you for being an inspiration. Thank you for being a Rotary Day.